embarrassing welcome, but I guess I've been interested in PNH for a long time, so it's nice to be recognised for that. I'm going to today speak to you about our experience of PNH, which, as Professor Teen said, we've been interested in for now over 25 years, and it's 15 years since we first treated patients with what became eculizumab or Soliris. I'm guessing that most of you who have visited the UK will largely have been to London and around London, which I'm really here to tell you is not the best place to visit. You need to visit the north of England, where is the most beautiful place. This is Leeds. This is our cancer centre in Leeds, which is the major city in Yorkshire, which I'll show you in a moment. We have most of the third floor of this building for haematology, for routine haematology, and then we have a large research group working mainly on CLL and on PNH and myeloma just next door. But within about 30 minutes of here, we have a nice open countryside. So this is the Yorkshire Dales, very close to Leeds. And you can see we have large spaces. We have animals and many sheep and some beautiful scenery. This is very close to an abbey which is 1,000 years old, so we have the advantage that we don't have earthquakes, so our buildings, some of them are very old. And so if you get the opportunity, I would visit at least the north of England and Scotland, which is, I think, a more attractive part of the world. And I'm slightly biased. I think the people are nicer as well, so so that's near my home. I have the privilege in PNH of having started and leading the national service for PNH, and this is a large group of people who are commissioned by the government to look after all the patients with PNH in the country since 2008. And there are two centres, and I'll talk a bit more about this later on, St James's in Leeds and King's College Hospital in London, that work very closely together to look after all of the patients with the disease. Not just patients on eculizumab, but all patients with a diagnosis. So I must acknowledge my colleagues in Leeds and in King's. So PNH has interested haematologists for many years, mainly because it's been a difficult disease to understand, and we now have a much greater understanding of the disease. Classically, there are three elements to the disease which are present in variable amounts. The classic presentation, and by which the disease gets its name, of course, is the episodes of hemoglobinuria, which usually happen intermittently, maybe for a few days, maybe in some patients continuously, and in some patients, as I'll show you, they never have episodes of hemoglobinuria. So you can't rely on this to make the diagnosis. This is actually the urine of the very first patient to receive eculizumab before he received it, and he's now been on treatment for 15 years and has not had any dark urine since then. What we've learned from the trials of eculizumab is the symptoms which are associated with PNH, which can be very profound: abdominal pain, difficulty swallowing, severe lethargy, out of keeping with the degree of anemia, erectile failure in men, is not due to the anemia, it's due to the hemolysis and the release of hemoglobin and absorption of nitric oxide. So one of the benefits of blocking hemolysis is to stop these symptoms. Even if the hemoglobin doesn't dramatically change, the patients are considerably better on treatment because they don't have intravascular hemolysis. About 50% of the patients, certainly in many populations, experience thrombosis at some point in their life with PNH, and historically in the West, certainly 1/3 of patients have died as a direct result of thrombosis. This shows a Budd-Chiari syndrome of one of the earlier patients we treated. There's certainly a variation globally in terms of thrombosis generally, but of the registries in the Far East, the South Korean registry, I'll show you some data, has a similar thrombosis rate, although some other areas have lower incidences. And the thing which is interesting us very much now, and I'll show you some of our work on this, is this association with bone marrow failure or mainly aplastic anemia. So 1/3 of patients with hemolytic PNH have a preceding episode of bone marrow failure or aplastic anemia. But the other 2/3 of patients, when you look at them in detail, also have aplastic anemia. So this is not a coincidence. There's a link between the two diseases, which I think will allow us to understand and is allowing us to understand why these diseases occur. And I'll come back to that in a moment. So I became interested in PNH really on the basis of a woman who, a young girl who survived aplastic anemia because she developed PNH in 1990 when I was at the Hammersmith. And with Lucia Luzzatto, who was my supervisor for my PhD, we started to show that the cells from PNH patients, which we knew were clonal, so these were an acquired clone of cells, had multiple deficiencies in all cell lineages within the hemopoietic system. So what we didn't know, and what was difficult to understand in the late 1980s, was why a single acquired mutation would lead to the deficiency of so many different molecules. But that became clear a bit later on when Martin Lowe and others described a linkage to the cell surface, a glycosyl phosphodienosyl or GPI linkage, and all of these molecules share that linkage. And so it then became clear that the problem in PNH was a mutation which affected the production or the survival of GPI structures. Our diagnosis of PNH, of course, has changed as well. So gone are the days of the sugar water test, the ham test. We've not been doing those for 20 years. We now use expression of these antigens, particularly on the red cells and the granulocytes and monocytes of patients with PNH. But that in itself is not trivial, because this is one of the tests, a flow test, where we're actually looking for the absence of a molecule rather than the presence of an aberrant presence of a molecule. And this shows the different patterns we see in PNH red cells. And so this on the top left-hand, on the top left-hand corner is a normal individual, the CD59 expression on red cells. So you can see a single population of cells and no deficient cells at all. Classically, what we would expect is that we might see, and what's in the books is the two populations of cells. So the normal cells, which may be transfused cells or might be normal cells produced in the patient, and a population of deficient cells which are completely deficient in GPI-linked markers, including CD59. And from the previous work of Wendell Ross and others, they had shown that these cells were extremely sensitive to complement. So they have about a 15 to 25-fold increased sensitivity to complement. However, there was a rarer type of PNH, which was shown right at the bottom of the slide, where we have a population of normal cells, but a population of partially deficient cells, but no cells, or virtually no cells, that are completely deficient. And these cells were known as type 2 cells because these cells only have a 3 to 5-fold increased risk of sensitivity to complement. And why this is important is because these patients don't hemolyze. They have enough complement protection from the CD59 that's there to stop hemolysis, but what they do is thrombose. And so these patients tend to present with thrombosis, but relatively little hemolysis. But what becomes clear when you start looking in more detail is actually this pattern where you have both type 3 and type 2 cells and normal cells is more common. So half of the patients have this pattern. And actually that means this patient has two different clones, which gives us a clue again as to the cause of PNH. This isn't, the patient for some reason is permissive for the development of PNH clones. And then we have more confusing patterns, for example this one where there's a single population but it spreads across the two, and then we have these ones where some of the populations are really not very clear. And so it's difficult to describe. We do use this nomenclature of type 2, type 3 and normal, but not all patients fit into these buckets. And then finally these patients, the one at the top right and the bottom left, are patients on eculizumab. So when we put patients on eculizumab, most patients stop being transfused, and then the red cell, so there's no normal cells left, because this patient will have only PNH hematopoiesis, and these are our cells which are protected from lysis. And the reason that's important is if for any reason this drug was stopped, these cells would lyse immediately and the patient would be in trouble. And so if we have to stop the drug, we have to think about the consequences of stopping therapy, which we rarely do in patients with large clones. So these are the two critical molecules for complement. These are CD59, which protects against the terminal complement cascade, CD55, which protects against the amplification at C3, which is a critical part of the pathway, and they are linked through this highly preserved structure, the GPI structure, to the cell membrane. And in 1990, I'd produced cell lines from patients, so we were able then to look at the structures in more detail in these lymphoblastoid cell lines, and we identified that all patients with PNH had a block in the production of this GPI anchor. So this is the chemical structure of the GPI anchor, which is highly conserved, and every patient we looked at was unable to transfer N-acetylglucosamine to phosphodienosytol. So the same step was blocked in every patient, which was somewhat unexpected. But then Tara Kinoshita from Osaka, who now is a close collaborator with myself, cloned, as he did with most of the pig genes, a gene called Pig-A, and that Pig-A gene was found to be the mutated gene in almost all patients with PNH. And you can see this is an old slide now, but each patient has a different mutation. So this isn't a congenital mutation, these are acquired mutations. So we understood at least the molecular and biosynthetic problems in the early 90s, but we still didn't understand why PNH clones occurred. And this light was shed on this by the work of Lucio Lozata's group, or David Arreton in 1999, which led to this and other work led to John Dacey and Bruno Rotoli to come up with a different hypothesis. So what David did was he looked at normal donors. So he took 9 normal donors from the lab and looked for low levels of PNH cells, and he could find PNH cells in every individual. So everybody in this room has got a PNH clone, or has had a PNH clone in the past. But that clone is weak because it's missing lots of molecules. It's not a malignant clone and will disappear. And so we know that everybody gets PNH clones at some point because of the mutation rate of the Pig-A gene. What I forgot to say was that gene is the only pig gene which is X-linked, and therefore a single mutation leads to the phenotype of missing of the molecules. So a single mutation leads to this phenotype, and so it's a very common mutation. So this led Dacey and Rotoli and Lucio Lozata to propose this double pathogenesis. Now, we've also been looking in more detail recently. We don't use Pig-A mutations as a diagnostic test because every mutation is different, but we use it within our research lab. We're doing deep sequencing of Pig-A. And I'll show you two patients. This first patient has a single mutation, 47% of the genes, and which if it's a female, that'll be all of the cells virtually have the same mutation, whereas the second patient has 8 discrete clones. So we see many patients with multiple clones, suggesting that these aren't randomly occurring, there's something that's selecting for the presence of PNH clones. So Dacey and Lucio and Rotoli came up with this theory that what we see in PNH is these are normal stem cells. We all get mutations that lead to a single GPI or more than one GPI deficient stem cell, but in a normal individual, that cell will die out and will not have an advantage. But under some selective advantage, and we, as I'll show you, now know it's an immune attack, this will lead to a selective advantage for PNH cells over normal, and that leads to the expansion and the development of PNH. And so we see many patients where the hemopoiesis is 100% PNH because the selection against the normal cells is so intense. And actually, many patients will survive aplastic anemia because of the development of PNH, which, of course, you don't want to have the disease, but it's better than having no blood at all and no white cells and no platelets. So these were the possible explanations for that. We know that the Pig-A mutation is not enough to cause PNH. We know that in normal individuals we don't get PNH, and in animals we don't get, if we put the clone in, we don't get PNH. There could be an immune-mediated attack, which is the case in most patients. There are 1 or 2 patients who have other second events within the clone, which lead to an expansion, such as the HMJ2. We looked very hard and can't find that in our patients. And then there was a story some time ago about resistance to apoptosis, which is probably not true. So I think we now have very good evidence that the reason that PNH occurs is because of an immune selective attack against normal stem cells. So if you get a normal marrow like this, you then get aplastic anemia through probably an aberrant attack against slightly abnormal looking stem cells leading to aplastic anemia. If you then get a PNH cell arise, there's then selective advantage, which leads to the PNH clone expanding. And one of my PhD students, who's now a colleague in Leeds, did a series of experiments in his PhD using the Dexter long-term marrow culture system. So this is a slight change in that system you use the patient's own mononuclear cells to grow a stromal layer and grow the stem cells on that. What we did was take a murine stromal layer, so we could grow a confluent stromal layer, and then you can put on the marrow cells of a patient or a normal individual, which then sit underneath the layer and produce progenitors. And so then every week we take off the supernatant, and we can test whether this culture is producing progenitors. And in a normal individual, we can keep these cultures going for 10 weeks or more and take off progenitors to show that and create, if you like, a marrow. And so we did this in PNH. And so this first line is the weeks across from the bottom. This is the number of progenitors produced in each week from a normal individual seeded with mononuclear bone marrow cells. You can see out to 8 weeks we're still producing progenitors. If we do the same experiment with PNH, so this is a patient with what looks like a normal blood count, normal platelets, normal white cells, and we seed it, the culture lasts about 2 or 3 weeks and then stops. So it's clear there's a bone marrow failure condition going on in this patient, although the cells, the blood count in the patient is relatively normal. If we, however, rather than using the mononuclear cells, we just take out the CD34 cells of the patient and see that on the marrow, we correct the defect. So there's something in the mononuclear cell layer that's suppressing the ongoing hemopoiesis in this model. If we then, rather than just the stem cells, we just take out the T cells, we have the same issue. So it's a T cell mediated attack against the normal stem cells that's causing the problem, and that's in some way sparing the PNH cells. Do we have any more evidence this is the case? Well, what we can do is we can look at the cultures out here and test whether they're PNH or normal. And we'd expect, if this was true, that the normal cells would increase over time in the culture of the PNH patients because the selection's been removed from the normal cells. And so we did that in these are just 2 patients. So this is a patient with PNH whose T cells were present, only survived 2 weeks, and there's no change in the normal compartment. If we look at the same patient now only out to 3 weeks, we see an increase 5 to 10 to 18% normal cells throughout the duration of the culture. And the second patient, again at 2 weeks, after 2 weeks the culture dies, but there's no significant change in the proportion of normal cells. But out to 4 weeks now we see an increase from 3 to 6 to 13 to 31%. So we now have a model that allows us to test the selective advantage for PNH patients. And we're trying to modify this to allow us to explore the mechanism. But the other side of the equation, now we know it's T cells, is there must be a T cell doing this, causing this problem. And so we've been deep sequencing T cells. I have a PhD student now working on this. And what we find, and this is a very early days, and it's actually one of our Chinese students who did this work in our lab, who showed that in PNH, we see some genotypes, as shown on the bottom right, that are much more frequent in PNH than in normal, suggesting that there's a small population of T cells that are causing the problem. And what we're now moving towards is identifying that and putting them back into the culture system to identify the exact epitope, if you like, that's being selected against, which I think will lead to much more effective treatments. So the conclusions from these experiments are that we now know that normal stem cells have a growth advantage over PNH cells in the absence of T cell mediated attack, but in the presence of T cells, the PNH cells now have an advantage over normal, and that leads to the growth of the PNH clone in PNH patients. And so modifying that diagram I showed you before, the first part is the same, but now we know this is a T cell mediated attack which leads to the expansion of PNH cells in the vast majority of patients. We have 1 or 2 patients out of about 50 that don't follow the same pattern and may well be an inherent problem in the cells, but most patients follow the same pattern of selection. So that was where we're going scientifically, and I think this will lead to treatments potentially, hopefully, for aplastic anemia and for some MDSs. So now our experience of PNH. So the first couple of slides I'm going to show you is that PNH is difficult to diagnose, and we know that there's a delay in diagnosis in PNH still, even in any country, of about a year on average from the first symptom the patient presents. It used to be several years, it's got shorter. And one of the main challenges for that are, first of all, patients don't present in a classical way, so they don't always present with the intermittent black urine and the abdominal pain and the severe lethargy and the typical symptoms. And secondly, they don't usually present to hematologists. They often present to gastroenterologists, urologists, neurologists, depending on where the disease is affecting. And so it's difficult for people to think about the test, you have to think of the test before you can do it. I think most labs around the world now who have a good flow cytometry can diagnose PNH if someone asks the question. So it's thinking about it. So we looked at our first 145 patients who we treated with eculizumab, and I'll show you the rest of them in a bit. And this is the symptoms they presented, the first 102 patients, the symptoms they presented with initially. And only half of the patients had hemoglobinuria. So although the classic is to have intermittent black and red urine, this is only half the patients present with that. The others may only have it once or twice, whereas others will have it every day or every second or third week. So it's very variable. What we see as the most prominent symptom actually is fatigue. So 2/3 of the patients have sometimes very severe disabling fatigue because of the hemolysis, and then a variety of other initial presenting symptoms. If we look at the distribution of patients from those, there's no difference in gender. The median age is 38, but there's a peak in early adulthood. This follows the distribution of aplastic anemia. So we see this early peak. The youngest patients we've diagnosed has been, I think, 5 years of age, and the oldest patient has been 88. So there's all ages, but the peak is in late teens, early 20s, which follows the aplastic anemia distribution. These are the patients we should screen. Of course, hemolytic anemia, hemoglobinuria is clear. We screen all our aplastic patients, and we screen them if they're negative annually, because it can arise a year or two after the diagnosis. Hyperplastic MDSs is useful in unexplained cytopenias because the non-severe aplastics, the marrow can actually be quite cellular if you get a cellular bit. And if you find a PNH clone, even a small clone tells you this is an immune-mediated attack against stem cells. So it helps you in terms of the diagnosis, and actually in most series suggests that those patients are more likely to respond to HEG cyclosporin if they have a PNH clone. So it helps you with treatment. And so we would certainly, in unexplained cytopenias, consider it's a useful test. And then thrombosis, but only really those patients with unusual sites, so Budd-Chiari, cerebral vein, and intra-abdominal thrombosis. Arterial thrombosis, strokes and heart attacks in a young age with no other cause. We've seen a few patients diagnosed in that way. So we wouldn't screen every thrombotic patient where there was an obvious cause. So historically, the management of PNH until, the drug was licensed 10 years ago, was really supportive. So transfusions, actually patients often didn't get iron overload because they lost iron in the urine. Anticoagulants, we used warfarin. It was quite effective to stop the first thrombosis, but very ineffective at stopping subsequent thrombosis. So one of the biggest fears, and I've managed a few patients like this, is that patients get one thrombosis, then they start thrombosing multiple major vessels until they die. And that's one of the major advantages of eculizumab. It stops that cycle of thrombosis, which is almost certainly due to increasing complement activation. Obviously, support red cell supplements such as EPO, but they don't really work because they create more hemolysis. We had a big debate with particularly Americans about steroids. We were not big fans of steroids because you need high doses to modulate complement, and too high a dose for a patient to have chronically. And so we had a lot of patients who were actually harmed by steroid use, and the responses are really not usually very, very good. I'll talk in more detail about transplant a bit later on. But certainly before we had effective therapy for PNH, we did more transplants than we do now. But obviously there's an issue of both the risk of the transplant and also GVH, which I think we're all familiar with. So I think when we think about managing PNH, we need to manage the two elements of the disease. PNH hemolytic side and thrombotic side, and the bone marrow failure side. And often the two things present in the patients at the same time. So we'll often have to decide which one to treat first. A patient with severe aplastic anemia and a large PNH clone, we would probably treat the aplastic anemia first, and then only deal with the PNH if it became hemolytic later on, unless there was a crisis such as a thrombosis, where we might have to treat the thrombosis first. And then sometimes we have patients who have PNH and evolve into aplastic anemia, and then we have to manage the aplasia while on eculizumab. So one of the advantages in the UK and we have a National Health Service, so all our healthcare is government funded, and there are various laws. This is a white paper which leads to laws in the UK, and we've had a very strong history of services for rare diseases, on the basis that the government and the people really decided that patients should not be discriminated against because they have a rare disease, and therefore we are prepared to spend more money for those patients because otherwise we wouldn't have any treatments. And so we have about 70 different rare disease services in the UK across all of medicine. And when in 2007 the drug was approved and we'd done all the trials, as you heard, and we had a lot of patients on treatment, I applied and we got funding for the National Service, which funded us from April 2008. And our instructions from the government are we have to enable equal access to the service for patients wherever they live in the country. So whether they live in Leeds or they live 200 miles away from Leeds, they have to have equal access to not just the treatment, the eculizumab, but also our advice and the service itself. This is data from the end of last year. We review our data in the sort of November of every year with the commissioners. And at that time, since April 2008, we'd reviewed 513 patients with PNH between the two centres, so Leeds, which is the larger of the two centres, and King's College. But we work very closely together, as I'll show you. At the time, we had 245 patients still on eculizumab. We prescribe the treatment. We see all the patients regularly, every 6 months if they're stable. And so we're very familiar with all of the patients that we manage. That's across the two centres. And we treated a total of 303 patients in the UK. The average duration was 6 years. We now have patients out beyond 15 years of treatment. So many of the 11 patients in the first trial are still on treatment. And our patients receive the treatment at home. So we have some less sales tax. There's no sales tax if drugs are delivered at home. So there's an advantage to having home care nurses. And so that's very convenient, of course, for patients. So this is the UK. So I was asked, you asked me before about where Leeds was. Well, this is the UK. This is about the border of England and Scotland, and obviously Wales is here. Ireland we've hidden. So Northern Ireland is hidden under our names. Leeds is one of the major centres near Manchester and Liverpool in the north of the country. The pictures I showed you of the countryside are really of this part of the world, which is very pretty. In our service, we work very closely with King's, and in the orange and in Scotland and Wales are the patients that we look after from Leeds, and then King's College look after the London patients. Of course, there's a very dense population of people in the southeast. In order to see patients and have equal access, we do clinics in Manchester, Liverpool, Birmingham, and in other places around the country. So every 12 weeks, we travel to those places and see maybe 25 patients from that area. So they rarely have to come to Leeds to see us, unless they go into a trial, when they tend to have to come to Leeds for the trials. So we work very closely with King's. This is the distribution. Most of the population of the UK is in England, and that's where we see most of the patients. We see about half the patients are not on eculizumab, and about half the patients are on eculizumab. So it depends on clinical criteria, which I'll show you in a moment. So this is the result of the very first trial that we did in PNH. I'd worked with Alexion since the early 90s on complement, because they were interested in complement. And in 1999, I heard from Russell Rother, who's a good friend of mine now, no longer works with Alexion, who was a scientific officer, that they'd developed an antibody that blocked terminal complement. And that's obvious. The one disease we know complement is critical for is PNH. So I approached them and said we should do a trial, but they decided it was too rare to do a trial in PNH. There was no ultra-orphan diseases, so they wouldn't let us do a trial, and I don't think they believed we could recruit the patients. So after about 2.5 years, Russell and myself continued to ask, and eventually they said, yes, you can do a trial. And so we did this first trial, which was meant to be 10 patients. We actually treated 11 in the end, 9 in Leeds and 2 in London. And we agreed the trial in February. We started the trial in May. We had a ASH presentation in December, and it was published in the New England Journal by early 2014. So it's probably a very rapid trial development compared to our CLL trials, which take much longer. One of the challenges with trials in PNH is what do you use as an endpoint? Because we can use transfusions, but not everyone's transfused. We can use thrombosis, but they're very rare events for each patient. We can use hemoglobin. But the obvious thing was to use urine, because the urine is a classic marker, a clinical marker of the disease. So I produced a scale which is this scale, so black, which is the more severe end, of course. Normal is probably the first 4. And so every morning the patients would record the colour of their urine. So just to show you how much respect I'm treated with it in my clinic in Leeds, one of my colleagues, who's a very good friend of mine, has renamed this chart Peter's indicator of severity of symptoms, or you can fill in the rest. But nothing's ever new. So we produced this chart so we could do the trials, but actually in 1866, the Queen's physician, Sir William Gull, who's shown here, produced a scale for urine for CH, cold hemoglobin, and PNH, which had different colours, so indigo down to amber, and this is a patient scoring his urine every morning in 1866. So that when you think you do things that are new, there's always someone who's done it before you. So. And he was the first person to describe PNH at all. I'm not going to go through the trials in detail because they're well published. I'll just show you 1 or 2 slides before we talk about our current experience. LDH is probably the best marker of intravascular hemolysis, and many patients are in the many thousands, or up to normal in Leeds is 430. And if we look at the trials, what we see, this is the randomized trial, so placebo, and then switch over to active treatment at 6 months, or the other 3 trials, the Pilot, Shepherd, and Triumph, and there was a Japanese trial, the Aegis trial. And what we see is every patient responds very quickly in terms of stopping the intravascular hemolysis. There are a small group of patients in Japan who have a polymorphism, which means they don't respond to eculizumab. It's about 3% of the Japanese population. We haven't seen that in PNH patients in the UK. There's been 1 patient with AHUS who's had that in the UK, so it's a very rare mutation. It's certainly not seen in other parts of this part of the world, as far as I'm aware. And that becomes obvious because the LDH doesn't go down, because eculizumab doesn't bind. And this led to publications, and all the studies were published, and we had 195 patients treated, which led to the license of the drug in 2007. And this shows some of those publications. In terms of going back to the UK, we have to have a national service so every patient gets the same treatment. And the way we do this is by having monthly multidisciplinary team meetings by video conference with the other centre. So every new patient is discussed by all the clinicians who manage PNH. There's 6 of us now. We have regular morbidity and mortality meetings if there's any problems with patients. We do bone marrows in every patient before we start treatment to exclude MDS, because we've had 1 or 2 issues with that, and that might lead to a different treatment, such as a transplant. We also do bone marrows when patients stop treatment, and I'll talk about that in a bit. As I mentioned, all the patients have treatment at home, unless they don't want to. We have 2 patients at the moment who go to the hospital because they prefer not to have it at home, but the rest of them have it at home. We have an on-call service where 1 of us is always available, and the patients have a record to keep a record of their own blood counts because they go to the local centre and our centre as well. We've defined criteria for treatment, so these are not funding criteria, but if a patient fulfills these criteria, they can have treatment. So it effectively does mean that the drug would be funded. This is the criteria from 2011, and what we said, and this is from the trial data largely, transfusion-dependent patients, or those patients with complications, thrombosis, renal failure or pulmonary hypertension, pregnancy, and I'll show you a little bit of data on pregnancy a little bit later on as well, and then patients with severe hemolysis who had severe anemia. but didn't need transfusions, because some of our younger patients could run hemoglobins of 70 or 80 and not need transfusions, but were very symptomatic. But what we found was that we had patients who actually maintained hemoglobins of 10 or 11, but were very symptomatic. So in 2013, November 13, we changed our criteria to remove the hemoglobin requirement, but to say the team had to agree to treat patients. Since then, we've been following very carefully whether this has increased our use of eculizumab, because obviously we don't want to start using it in an uncontrolled way. And of the patients, this is for between November 13 and 16, we started treatment in 78 patients, and only 4 patients were treated for the extra reason of symptoms, really. So it hasn't really changed the use of our drug. Most patients are still treated because of hemolysis, thrombosis, or transfusions. So what's happened to the patients? This is from the end of last year, 303 patients. So 245 patients remain on treatment. 58 patients have stopped treatment or transferred, so 18 have died. I'll show you those later on. We have some who stopped because of remission, which was then 5. It's now up to 7 or 8 now. We stopped some because of pregnancy, because pregnancy is an indication, but only during and for 3 months postpartum. So then we would stop the patients then. But many patients then go back on it if they get symptomatic. And then some get transplanted, and I'll talk about those as well for other complications. What about the real-world experience? Well, we see a reduction in transfusions. This is the transfusion rate before and after eculizumab for the 12 months. Not every patient stops being transfused, but the ones who aren't transfused are still not getting the complications or many of the symptoms. So I don't believe you can use transfusions as a guide to whether you should continue treatment or not, because the reduction in renal failure, the symptoms, the thrombosis is seen in both groups, and I'll show you that from the South Korean data in a moment. And the reason for the transfusions is multifactorial. We get some people with bone marrow failure as well, which we have to deal with. Some people are underdosed with eculizumab, and we have to think of higher doses in those. And maybe with the new drugs, it won't be as much of a challenge. And we have patients with extravascular hemolysis. So the patients load up with C3 and have extravascular hemolysis leads to anemia. One of the concerns, of course, and what we didn't have as an endpoint of the trial was thrombosis, and this is one of my patients who presented in about 2005. She'd been my patient before, in her 30s, who had headaches for about 6 weeks and a weak hand. She came in, she had a CT scan, which was normal. She had an MRI scan, which was normal. I had to persuade the radiologist to do an MR angiogram. This is the result of that. So there's no sagittal sinus, it's completely thrombosed, and she's got, these are all collaterals. And so she's got a well-established cerebral vein thrombosis. And I'll come back to this patient later on. She went into one of the trials and has done very well. So you have to think of thrombosis and encourage and do the appropriate investigations, which angiography are certainly the best. We know from historic series that about half the patients experience thrombosis, and of the deaths due to PNH, about half the deaths were due to thrombosis or indirectly due to thrombosis. And if you think about thrombosis, generally, the PNH actually is the most thrombogenic disease that we see. So if you look at the inherited thrombophilias, antithrombin, protein C, protein S, or the factor V Leiden, prothrombin mutations, the increase in risk is about 7 or 8-fold at most. But with PNH, there's an over 60-fold increase in risk. It's not a major problem for the population because PNH is so rare, but for the individual patient, it's a major, major concern. And the other important thing is we have a therapy, of course, that stops the thrombosis. So it makes a difference if you make the diagnosis earlier. This is data from a South Korean registry run by Young-Won Lee, who now has included the patients in the international registry that I know you have open in Taiwan as well, and I chair. So what you see from this is that the risk of blood clot is linked to symptoms and hemolysis. So patients who have a high LDH, abdominal pain, chest pain, dyspnea, hemoglobinuria have a higher risk of thrombosis than those patients who don't. So the more hemolytic patients have a greater risk of thrombosis. And if you look at transfusions, so this is splitting the patients by no transfusions or transfusions from the South Korean registry, the transfusions do not define the level of symptoms. And so many patients have severe abdominal pain, needing opiates, dyspnea, chest pain, and don't need transfusions. And so it's a very poor marker of disease severity because it depends on how well the marrow is functioning as to whether you need transfusions and how well you can cope with low hemoglobins. What about thrombosis? This is from the trial, so we see a significant reduction in thrombosis. We couldn't use this as an endpoint, but we looked at it prospectively, and you see the reduction in thrombosis in the trials. And if you look at the patients only on anticoagulants, this is the risk: 11 patients per 100,000, down to less than 1 patient per 100,000 with a thrombosis, or per 100 patient years, sorry. And so eculizumab in the trials was effective. And in our real world experiences from the UK data, we see exactly the same pattern, that we see thrombosis before and we don't see thrombosis afterwards. 1 or 2 patients do get thrombosis, and at least one of these patients was breakthrough because the dose was too low, and the patient then got Buchiari when they were not blocked. So going back to the eculizumab, when we did the first trial, we didn't really know what the correct dose was, because the previous trials were in rheumatoid, nephritis, and other similar diseases, and they didn't try and block the complement continuously. They tried to block it intermittently, and we knew that in PNH we'd have to block it all the time. And so we used their data. We couldn't do a phase 1 trial in PNH, so we had to estimate the dose from the data from those other diseases. And this was the dose that we came up with, so I take some responsibility for this. So 600 milligrams to load every week for 4 doses, and then every 2 weeks, 900 milligrams continuously. Within the trial, we allowed a variation of 12 to 16 days, really just for convenience, and that led to the license. We were always concerned about meningitis. We vaccinate all our patients. We have the Bexsera B vaccine now for the last 2 years. We give our patients penicillin prophylaxis, or erythromycin if they're allergic. We've seen about 6 or 7 cases of meningitis in the UK in the last 15 years. And only 1 patient's had a rash or photophobia or the symptoms. Most of them have sepsis and hypotension. And if untreated, patients can die of the complication. In the UK, we haven't had that because we treat them quickly, but there have been 2 or 3 deaths internationally for, when patients haven't presented early with meningococcal sepsis. So it's something we're very anxious about. So that's eculizumab. So if you look at the dosing of patients, so that dose is right for most patients, but what we found this is our real life experience of the 245 patients, that just under 80% are on the 900 milligram dose, but some patients need a higher dose. And so what we see is patients just before a dose, because the trough level is critical, will either increase their LDH, get symptoms, or will drop the hemoglobin. And then when they have a dose, it switches off again, and then 10, 11 days later, it happens again. That's the classic breakthrough. And when we've measured the levels of both eculizumab and complement, and we increased the dose accordingly, most patients who need a higher dose are on 1,200 every 2 weeks. It's far more convenient to keep it at 2 weekly than going to 12 days. And so since we've been able to, we've used 2-week dosing. Pregnancy is slightly different. We see higher doses in pregnancy, so I'll talk briefly about that. And when we increase the dose in those patients where the levels are low, this is the eculizumab level that we measure. We were aiming for about 100, so the group had 50, and with the increased dose, we increased to the trough level we're targeting. And also that leads to a decrease in LDH. So our limit of up to almost 430, and you can see it's double for the patients who are breaking through. And when we increase the dose, we bring the level down, and the patient comes under control. And transfusions, this includes 1 patient who was very heavily transfused because he had sideroblastic anemia as well and a massive spleen. If we remove that patient, because I don't think that's hemolysis, we can see an improvement. But we don't stop the transfusions completely, but we see an improvement in transfusions with increasing the dose in selected patients. The reasons for increasing the dose is shown here. So we measure the level of the drug, we measure the complement level as well, CH50, AH50, CH100 if you have that assay. We see some patients with clinical breakthrough or incomplete blockade. And so we've increased it for those reasons. Hopefully with the new drugs, and there are several new drugs being developed now, that will get the dose more accurate, more better for the whole group of patients, so that only a few patients will break through rather than 20%, which I think is too high. This is the second patient ever to have eculizumab. So this gentleman had it a week after the first in my clinic. He's a farmer from Yorkshire. Farms rhubarb, which is fruit. Vegetable, don't know. For many years, he was transfusion dependent for over 10 years, having 4 units every couple of months, quite symptomatic. This is his red cell clone, shown here because it changed with transfusions. The yellow is the granulocyte clone, so all of his hematopoiesis is PNH, and he was transfused. He started eculizumab in May of 2002, and he continues on it to this day. You can see that he stopped being transfused, so his red cell clone went up to 100%. So all of his hematopoiesis has been supported. He had a parvovirus infection, which led to a transfusion, which is why he dropped here. But since then, this is 2012, he's not required transfusions again. So we have to monitor these patients because they have a compensated extravascular hemolysis that will switch off with things like parvo or infections. This is a second patient. In fact, this is the patient with the sagittal vein thrombosis that I showed you the MRI angiogram of before. So she started treatment in 2005, as you can see here. At the time, her granulocyte clone was over 95%. Red cell clone was high. She started because of the thrombosis. And then subsequently, her granulocyte clone was gradually reduced until 2011, when it reached 10%. And then we stopped the drug. So our practice is to stop the drug at 10% because we don't see hemolysis or complications in patients with clones of that size. Her clone has continued to decrease and is now below 1%. She sees us once a year. She has no more thrombosis. She's off anticoagulation and is very well. And so this pattern is of the patients who improve is the more common pattern, though we see a reduction over several years, about 5 or 10% a year dropping down. So it's important to monitor the clone size to see what's happening with the patient. I wouldn't stop the patient too early because we will see hemolysis and complications. So I would continue until they get down to 10%. This is an unusual patient. This is the oldest patient we ever treated with eculizumab, actually. She was 88 when we started her treatment. She presented with Budd-Chiari syndrome and several of the thromboses in her 80s. She didn't want to have treatment. She felt she was too old to have treatment. We don't have a rule about that, so we wanted to treat her, and her family wanted her to be treated, so they encouraged her to have therapy. She had therapy for just about a year, as shown here, and remarkably, her clone disappeared very quickly. So within just over a year, the clone went down to 10%, and we stopped the drug. And she's now still okay in her 90s and no more thrombosis. So occasionally you see this pattern, but this is less common. If you look at our patients in total, this is actually from 2 or 3 years ago now, and we need to update it because we've got more patients that are reducing. We see a reduction in the clone size in about 10 or maybe a bit higher percentage of the patients, where there's a slow reduction in the clone. Many of the patients remain stable. But we know from our previous experience of following up old series, the DAISY series, for example, it can take 10 or 20 years before patients will remit if they're going to spontaneously remit. So we may need to follow these patients for longer. This is one of the patients in the original trial who started treatment in 2002. She did quite well, clinically did very well, but she still needed the occasional transfusions. And she's a very bright young girl. She was at university when she started her treatment. She got married when she was joined the trials, and then we had the drug approved in June 2007. So this is when it was approved in the UK, and 1 week later she appeared in clinic pregnant. And of course, within the trials, the patients couldn't continue on eculizumab. They had to stop the treatment. So we had no experience of eculizumab in pregnancy. And the license said that you should continue the drug if the benefits outweigh the risks. Well, we knew what the risks were of not having the drug, because the maternal mortality is around 10% in pregnancy of PNH, if you believe the literature, and the fetal loss is very high. So we knew there was a significant risk, which actually stopped many women getting pregnant with PNH. We didn't know what the risks of the drug were, although we knew that, I did a lot of research at the time, over 100 babies had been born on other monoclonal antibodies with no obvious teratogenicity. So we decided, after a lot of discussion, she would continue on her eculizumab on treatment during the pregnancy. Her transfusion requirement went up, which we see in pregnancy, and then she broke through, so she had clear hemolysis in the second trimester. And this is seen in over half the women who get pregnant. So if they've been stable on therapy and then they get pregnant, they often break through. And then once they deliver the child, they go back to their original dose. And we've had to increase the dose of eculizumab in some patients up to 1,500 milligrams or even 1,800 milligrams to get through the last trimester of pregnancy. But we know there's a very significant risk of breakthrough, so we're very anxious about it. So this is what happened. So we couldn't increase the dose because we had no data, but we went to 12 days. She had no further hemolysis. She delivered a 4-kilogram baby, which is this young gentleman here, in 2008. No maternal or fetal complications. We measured the eculizumab in the cord blood, and there was none, or in the breast milk. So she breastfed. She went on and had a second baby, 2010, and she broke through earlier, actually, at week 16. Again, no complications. And then she went on and had a third baby, and so this is Louise, the patient, and the 3 babies. She's actually just had a 4th baby. I've not got a picture of the 4th baby, and she's promised me she's going to stop because it's getting more complicated to manage. So, but I think it shows you that patients, we would never have expected this to happen in PNH before. And so it changes. I mean, half the patients are women. We expect to have children, and I think it means they can lead a more normal life. They come to clinic. We've now had 50 babies born in England on eculizumab, so our clinics are sometimes full of children running around. So this is a nice thing. What about survival? This is the data. When I was at the Hammersmith, Sir John Dacey had been there obviously before, and he had an interest in PNH. He diagnosed 80 patients, which weren't followed up beyond the early 70s. I found the files and followed up the record of those patients in the 90s. So these are patients who were treated with supportive care, obviously way before we had actually even platelet transfusions. So this is really supportive care with no anti-complement therapy. The patients were all ages, so of course, if you follow them for 25 years, not every patient will survive anyway. What we found was that the median survival in untreated hemolytic PNH was about 10 years. About a third of patients were dead by 5 years. If you look at the age-matched control, this is from our census we have in the UK, at 25 years, about half the patients had died as an indirect or direct result of their PNH. About a quarter were alive. In fact, 12 of those patients had remitted spontaneously, and we got samples from them to show that they didn't have PNH in the myeloid series, although they had it in the lymphoid series as a trace, so we could see that the diagnosis had been there. And then a quarter had died of other causes. If we look at our PNH patients, this is from a few years ago now, match it with a normal control. These are the first 150 patients we treated in Leeds. The survival is very similar to normal. And the more up-to-date data now out to 12 and beyond years is similar. So we've stopped the complications, the thrombosis, the renal failure, those symptoms, but we still probably aren't quite normal because there's an underlying problem with aplastic anemia and myelodysplasia, which this drug will not treat. And so we have to consider managing that. What about the deaths? This is now a couple of years old, but these are the first 18 deaths, and most of them are due to bone marrow failure or attempts to treat bone marrow failure. So transplant, bleeding because of low platelets, or variceal bleeds from Budd-Chiari syndromes, and occasional other causes, but not directly of PNH. What about transplant? Looking at the EBMT data, this is Regis de la Tour's data from Paris. He looked at all the EBMT data. This is before the eculizumab era. 211 patients were transplanted in the EBMT, of which just over half were, the primary reason for transplant was aplasia. The rest were thrombosis or active PNH hemolysis. Most of the patients, 2/3, were identical siblings, and then other unrelated donors for most of the rest. Most of them bone marrow because of aplasia, so we would obviously use bone marrow as the source still, and GVH prophylaxis was in those days. Engraftment's not a major problem. Most patients engraft, but GVH was a major problem. So chronic GVH is seen in extensive chronic graft-versus-host in a quarter of patients. This is the outcome of those patients. So 2/3 alive at 5 years. If you split them by their different groups, the hemolytic patients is 90%, but we see much better survival with PNH, and thrombosis is even worse. And so we will cure some patients, but obviously some patients won't survive the procedure. And what Regis did was take 20 patients from his PNH registry currently now match them with patients from the EBMT to compare the hemolytic patients. You can see there's the non-grafted ones treated with eculizumab do better than the patients who are transplanted with allo. And so we reserve transplant for patients with bone marrow failure. These are the 9 patients up until the end of last year that we transplanted with PNH in the service. So the top 5 were aplastic anemia, were given aplasia type conditioning before the FCC regime. 2 of the patients died, 3 of them survived. And then of the MDS patients, some of them had some blasts, so they had more intensive conditioning. 3 are alive and one has died. So we have 6 of patients alive out of 9 that we transplanted. But these are selected patients with poor disease and bone marrow failure and clonal evolution. Monosomy 7, for example, would be a reason that we would consider treating a patient, transplanting a patient. So obviously the pros of the transplant are that it's curative potentially, and that it's probably cheaper than anti-complement therapy for 15 or more years. But the problem is that the outcome is worse in patients with hemolytic or thrombotic disease than with anti-complement treatment. And we have obviously the continuing issue of GVH. So our approach really is to, as I mentioned before, is to treat the dominant feature first. So if the patient's aplastic with even a large PNH clone and not hemolytic, we would treat the aplasia. If they had an indication for transplant, we'd transplant them. If they didn't or didn't have a donor, we'd use ATG and cyclosporin. And then, if necessary, use eculizumab later. If there was a reason to use eculizumab, we'd use that first. And we do now next generation sequencing and FISH and cytogenetics, obviously, quite regularly, a diagnosis, and if there's any change in the counts, because that would change our treatment. So the summary, I think, for eculizumab now is that eculizumab has made a major impact on the treatment of PNH. It's manageable, but there is some toxicity. We will always have an issue with meningococcal infection that we have to manage, and so we have to advise patients to seek advice if they get temperatures, if they don't feel well, and we still worry about that. It's effective at the complement issues of PNH and normalizes survival. It's not quite normal because of the MDS AML. The problems we have are the intravenous therapy. We've had patients down on treatment for 15 years, every 2 weeks, which is inconvenient for them. It has no effect on aplasia, but maybe our understanding that will help. And of course, the cost is not inconsiderate. As you know, because you have, I think, trials with the agents, we now have multiple C5 inhibitors in development. We have a long-acting antibody which lasts for 2 months or even 3 months, one infusion every 3 months, which obviously has the potential to make a big impact. We have patients who can self-administer some subcutaneous small molecules. We have 2 or 3 different small molecules which are being developed for PNH. We also have inhibitors to different parts of the cascade, so which may help the patients who don't respond as well. So we have a very interesting data emerging with C3 inhibition in patients who have continuing extravascular hemolysis, although we have some anxiety about blocking the cascade higher up and the risk of more infections. So we're watching that closely, and we're using it with eculizumab at the moment for those patients. I think in the future that it's going to be moving towards understanding in more detail the link between aplasia and PNH, and how can we produce therapies that truly modify the disease? Can we mimic the PNH and block that attack and therefore allow patients to recover? And that might lead to the treatments for aplasia and MDS as well as for PNH. Diagnosis, I highlighted the importance of considering the diagnosis. I think we can all do flow cytometry now because there are situations where we need to use anti-complement therapy as an emergency. So if a patient gets a thrombosis in the UK, they'll be on treatment that day, because we know that if they get a stroke, it's critical to stop the thrombosis immediately. And we've certainly had patients where the diagnosis hasn't been made and they've had major problems. And finally, just share another patient. This is a young gentleman who was diagnosed at the age of 19 with aplasia, then PNH, really stopped doing sport because he was a very keen sportsman, but returned to sport when he started eculizumab, and he does things which I don't think I'd recommend him to do, but they're leading normal lives, and he's now rock climbing and back to his normal activity. So many patients have a normal existence now. And finally, to thank the team. This is the Leeds team. That we actually Anita Hill is now leading the NHS, the patient service. I'm more focusing on the research side as well as doing the clinics. So I always go at the back, because I always say the tallest should go at the back. This is our chief executive who comes out when we have a camera and is always on the photographs, but doesn't see any patients. So, and the nurses, of course, who look after the patients on a day-to-day basis. Thanks for your attention.